Good afternoon and hello to all. Welcome and thank you for joining us for this important seminar exploring a housing-based healthcare partnership model for vulnerable populations in Los Angeles. I am Tim Kawahara, and I am the Executive Director of the UCLA Ziman Center for Real Estate, a joint research center of the UCLA Anderson School of Management and the UCLA School of Law. First and foremost, I and we very much hope that all of you and your loved ones are safe and well. COVID-19 has obviously disrupted our lives in significant and unprecedented ways. And this program is no different. It was originally scheduled to occur in person at UCLA over a half day. In lieu of that, we have decided to offer the program remotely, albeit in a very condensed format and with some minor modifications. In many ways, COVID-19 has amplified the need to engage in serious and meaningful conversations regarding our healthcare system and how we deliver healthcare services, particularly to the most vulnerable among us. You might be asking yourself, why is a real estate center at a business school so interested in the topic of healthcare? Good question. Well, while we do engage in teaching and research around issues of finance and investment, the Ziman Center employs a multidisciplinary approach to real estate. This includes looking deeply at issues such as urban design, architecture, engineering, transportation, affordable housing, homelessness, sustainability, climate change, public infrastructure, technology, social equity, and yes, healthcare. We know through data and research that the built environment and housing is a significant social determinant of health. So this is an important subject matter for us to undertake. UCLA also happens to be home to one of the top schools of public health in the world, the UCLA Fielding School of Public Health, and we are grateful to count them among our partners on campus. Our external partners on this particular program include National Well Home Network and Valon Consulting, and you will meet representatives from both of those organizations shortly. We were all introduced to each other by a group called SCANPH, for the Southern California Association of Nonprofit Housing, and we are grateful to them as well. And with that said, I am delighted to introduce my colleague, Christina Green, who directs the Ziman Center's Housing as Healthcare initiative, to begin the formal portion of the program. Christina.
Thanks, Tim, and welcome to all the UCLA students, faculty, and staff, and the affordable housing, real estate, healthcare, public health, and social services industry professionals, and our special guests in the audience this afternoon. As Tim said, my name is Christina Green, and I'm the program manager of the Ziman Center's Housing as Healthcare initiative here at UCLA. Just a few housekeeping reminders before we start. Please do use the Q&A feature found at the bottom of your screen, or it might be at the top, and enter any questions there. We also recommend that you select gallery view or the side-by-side option in Zoom to enhance your personal viewing experience. I am delighted to introduce this esteemed group of panelists that we have brought together today and the unique perspectives that they each bring to this conversation. In alphabetical order, we welcome Gary Blasey, Professor of Law Emeritus at the UCLA School of Law, for his expertise in policy serving the homeless. We also welcome Sharonda Carter-Cottrell, I Wish Wellness Nurse at Vista Tower Apartments, Creative Housing Services, for her firsthand knowledge of housing-based care coordination here in Los Angeles. We have Diane Davis, Vice President of Partners in Care Foundation, for her focus on housing-based health education for vulnerable populations. We also have Nancy Rocket Eldridge, the CEO of National Well Home Network and the original creator of the Support and Services at Home, or SASH program, as a population healthcare model. We welcome Sarah Hunter, Senior Behavioral Scientist at the RAND Corporation and Professor at the Pardee Rand Graduate School. She's the Principal Investigator of LA County's Housing for Health Permanent Supportive Housing Program for the Homeless. We also have Allison Klurfeld, the Director of Safety Net Programs and Partnerships at LA Care Health Plan, for her command of public programs serving the vulnerable. We welcome Jenny Scanlon, the Chief Strategic Development Officer for the Housing Authority of the City of Los Angeles. for her expertise in housing and community development and coordinating services targeted to the most vulnerable in our city. We have Sadhna Thevaraja, Managing Director at Health Begins, for her perspective on how healthcare and social services can move upstream to address social and structural determinants of health. And we have Fernando Torres-Gil, the Director of the Center for Policy Research on Aging and Professor of Social Welfare and Public Policy here at UCLA, for his breadth of expertise in aging policy for vulnerable seniors. Our moderator and coordinator of today's discussion is Ayako Utsumi, the founder of Valon Consulting, advocate for the intersection of health and the built environment, and the original moderator of the first panel on this topic at SCANPH last fall. With that, I'll turn it over to you, Ayako.
Thank you, Christina. Special thanks to Tim Kawahara, Christina Green of the UCLA Ziman Center for Real Estate for hosting this event. To our distinguished panelists and audience, welcome. I open with a quote. Next slide. Next slide. Yes, the connection between the health and the dwelling of the population is the most important one that exists. Florence Nightingale had it right many years ago. Next slide, our agenda today. We have 3 goals. Goal number 1, explore the pain points that prevent housed vulnerable people from thriving for the long haul. Goal 2, review the elements of a housing-based partnership model called Support and Services at Home, or SASH. Goal 3, discuss what housing and healthcare wellness elements and partnerships we have in Los Angeles that can be strengthened. And we will end with Q&A. Next slide. Ground rules and definitions. Who are the vulnerable? For this discussion, they are the housed vulnerable seniors, or in the recent past, homeless persons residing in publicly assisted or low-income housing. The health and wellness system is defined as housing, healthcare, public health, mental health, social services that occur primarily outside the public or private doctor's office or hospital. I also include the built environment as part of the system. Geography. We're talking about our system here in the greater LA area. I will call on specific panelists to answer a question. Panelists get 2.5 minutes each without interruption. Other panelists may add comments at the end of the section. Again, audience Q&A at the very end. I realize we cannot do justice to the complexity of this topic or to the expertise of our panelists, but I'm confident that we can start this conversation and continue more in depth at a later date. Oh, and by the way, just between you and me, since the shutdown, I have only styled my hair on 1 other occasion, so you got me to do my hair? Good job. Okay, let's begin. Discussion primer. Next slide. We have a spending mismatch. 50% of our health is determined by healthy behaviors, but spending on healthy behaviors is only 4%. We don't need spending parity per se, but certainly we can do better. And it's not that easy to have healthy behaviors. Next slide. Picture a 15-minute doctor's office with a vulnerable person. The doctor says, eat healthy, exercise, take your meds on time, and reduce stress. Wait a minute, that sounds like my doctor. But anyway, here are some resources to help you. We'll see you next time. So for vulnerable people, what do you think happens with this 15 minutes of information when they go back home? So therein lies the rub. Healthy behaviors are difficult to maintain or correct without help, especially if you've had a lifetime of hardship. So goal number 1, next slide. Explore the pain points that prevent vulnerable people from thriving for the long haul, and speakers may consider COVID-19 in their responses. But what do I mean by thrive? I don't mean ice cream and amusement parks. I mean to live with purpose and meaning. People who live with purpose and meaning are more likely to engage in healthy behaviors. People who engage in healthy behaviors are more likely to have only necessary health care. Having mostly necessary health care is good for society. So I think of care coordination as a means to help people thrive and have cost savings to the system. So I'll start with Jenny Scanlon. As a public houser, what are the pain points experienced by housed vulnerable people to thrive for the long haul? Jenny.
Thanks, Ayako, and thank you for having me on the panel. You know, I guess I'll start by saying I initiated my career doing social work, and so I'm a little bit dangerous in my understanding of where our population is coming from. But I will say both within our public housing and our Section 8 portfolio, you know, what we find is we have a significant number of individuals who self-identify as disabled. So within our population of Section 8, we have over 60% identifying themselves as disabled. In our public housing, that's 20%. What we find is, you know, and this will be no surprise, I think, to your public health students, you know, I think poverty creates PTSD. I think that a lot of our residents, although they may be housed, are struggling with trauma. They're struggling with mental health issues. And I think that those present their own pain points, which are really the starting place for how you access health care, how you treat yourself and your family, and, you know, how much you're able to take in terms of information provided to you, and then actually process it and act on it. And so I think that, you know, we have to, what we find within the system is that folks are coming in to places where, as you said, they're having a connection either at a clinic or an ER, where they're seeing a doctor maybe one time, they aren't creating a trust relationship, they aren't creating that connection, and so the information is not as relevant to them, and it's not something that they can process. So I think the problem is there are no health relationships developed with their providers. So I think it, you know, it sort of starts with the individual, but I think we have system issues as well. So we have digital divide issues. We have a lack of access to internet and information. We have cultural divide issues. We have trouble with folks who come here as immigrants with speaking Russian, speaking Spanish, not having enough access to information in their own, not only in their own language, but that's sort of culturally sort of provided to them, so that, you know, we have an understanding of how their culture works. So, so again, that's just a starting point, but there are a number of pain points in our system right now.
Thank you, Jenny. Thank you. Very important points. Next, let's move to Sharona Carter-Cottrell. As a housing-based care coordination nurse in LA, you answer the question.
Thank you for the invitation to participate on this panel, and I'm more than pleased to share. The Integrative Wellness in Support of Housing, or IWISH program in our community has been effectively addressing many of the challenges presented in the population. There are 5 demonstration sites in our region in and around Los Angeles County that each face unique pain points, and over 200 more across the country. For our particular site, the largest pain point is the language barrier, as 98% of our residents are Korean only speaking. There are limited resources, and of those available, many are not able to accommodate the language requirement. Non-emergency transportation was an early evident need. The utility of the fire department has been our major option for same-day or short notice outings. In a survey taken early in the demonstration, several individuals indicated an interest in brain health and memory support. A notable resource was discovered, and the subsidy was prepared to address the interest. However, the language barrier ceased all progress. In an ongoing challenge to empower the residents with tools and support to take a diligent role in the self-management of care, it is an ongoing challenge. We recognize the unaddressed challenge of chronic pain affecting 38% of participants who reported having arthritis, and another 26.6% who reported other for chronic health conditions. A culturally appropriate solution with evidence-based Eastern medicine was proposed. We failed to implement the programming due to limited community space as well as concerns with liability. In relation to COVID-19 pandemic, we are seeing an increased risk of social isolation with extremely limited resources due to the language barrier. Humans are social creatures by nature, and it is unmistakable as essential in the well-being of our vulnerable community. Staying home is affecting the residents' consistency with healthy behaviors, primarily related to the physical state and socialization. The effects of the more sedentary and isolated routines are showing an increase in health and a decrease in health and an increase in risk of complications of chronic diseases. Access to medical care is affected as the participants' personal care provider offices are closed either temporarily or permanently. Specialty services are unavailable. This leaves emergency rooms or urgent care visits as curbed options. Residents in fear and/or precautions of the virus exposure are hesitant to seek or are postponing appropriate medical care.
Thank you, Sharonda. Okay, thank you, Sharonda. Thank you, and those are very important points. Diane Davis, as a health educator, what are your thoughts on pain points?
So hi, I want to thank you too for having me at this roundtable, I think is what I'll call it. I think, you know, our pain points are very different now under the pandemic than they were 2 months ago. But as I say, very different. You know, I think they all sort of fit in together. I'm basically I work at Partners in Care Foundation, and I'm the Vice President for Community Wellness there. We do health education programs across the county of Los Angeles, and we actually also have some grants that support us on a statewide basis as well. The programs that we do are the Chronic Disease Self-Management Suite of programs, which is the Chronic Disease Self-Management Program itself, Chronic Pain Self-Management Program, and Diabetes Self-Management Program. We also have a suite of falls prevention programs that include Matter of Balance and Tai Chi for arthritis. And then we have a group of exercise programs that we also provide, arthritis exercise and enhanced fitness. So up until, did you have a question?
No, so the pain points?
Okay, yeah, I'm getting there, I am. So up until, that's exactly where I was going. So up until, you know, 2 months ago, my main pain points I would have said would be language issues and language barriers, because I, like Sharonda, you know, I'm covered for Spanish. All of my staff speak Spanish. I'm covered for English because they're all bilingual. I have Chinese, Mandarin, and Cantonese speakers, but for the Korean population, you know, we get somebody hired on who can speak Korean, and like before I know it, they found another job and they're off, you know, doing that. So we are very much limited by who the staff is that we have, and the volunteers are who we have at that time. We do try to work in all of those populations. We have worked in the Russian population, we have worked in the LGBTQ population, but those can be significant issues. Honestly, also for me, a big issue in Los Angeles is transportation and traffic and the amount of time that it takes my staff to get to workshops, but also the barrier that causes to people who are trying to come to the workshops from other locations around the city. That all flip-flopped on its head under the pandemic, because all of a sudden we had to take all of the health and education programs that we do, and like I said, we worked in 100 low-income housing sites last year. So that's our primary location where we've worked. Okay. We have to take all of the programming that we did in those sites and take it online and find a different way. And the digital divide that was spoken about, I don't remember if it was Sharonda or if it was Jenny, but that digital divide is a huge issue for us now. We find that only about 50% of OLERs have access to the internet. Thank you.
Okay, thank you. All right, next slide. So Sadna Thavaraja, as a systems upstreamer, next slide. As a systems upstreamer, what are the pain points of providers, insurers, and our hospital systems to coordinate care for vulnerable people to help them thrive. Sadhna.
Thank you, Ayako, and thank you so much for the invitation from you, Christina, Tim, and all of the organizers. It's such a pleasure to be here. You know, you actually laid out an example of a doctor's visit that I think is really a great example of a pain point, right? Because what if the doctor knows that they are sending the patient back with information that isn't actionable for them? Maybe it's not actionable because they're not going to a home. What can the doctor do about that? And, you know, we work with provider groups, with payers, with systems where folks know that that's happening, right? And so we work at that intersection where integration happens for the healthcare partner and the social service partner as they're trying to address these factors that impact health so that, you know, we're not creating those pain points for folks that didn't get into this profession to not be able to help. And so that includes, you know, things like housing, but it also includes food, transportation, a lot of the other issues that we're seeing that drive health. And I would say, you know, on the COVID point, all of this work is just on overdrive and being accelerated because, you know, we were kind of working with folks that were kind of leaders in this field that were looking at ways to improve care for a variety of reasons. And with the pandemic hitting, it just really made all of that work become even more apparent. And I think Tim mentioned, you know, really amplifying the need. I've heard Dr. Amalawara Dino in New York refer to the two populations to care for in this pandemic as those who are infected and those who are affected. And we're really seeing that be the case. And how that works out is very different for providers versus insurers versus hospital systems, as you can imagine. And they're operating with different needs, incentive structures, wielding different kinds of power. And I would say across the board, there are some similarities. Everyone's talked about speaking the same language in terms of like the patient provider kind of interface. And I would say it's the same between the healthcare provider partner interface, right? We're just not using the same terms. And some of my friends here on this panel have heard me like harp on about this, but it's really such what feels like a simple point, but is so crucial to making partnerships work and thrive, is figuring out how to use the same terms, align on them, and speak the same language while we're trying to reach the same outcomes. Second is figuring out how to deal with data. It's always kind of tenuous, a little scary for folks to think about that. And that's something that we help navigate and get people from kind of being frozen space. The two last things are really embracing an equity mindset in doing this. And then finally, embracing a continuous improvement mindset. For folks who were doing this before COVID, a ton of stuff has shifted and they really need to be in that continuous improvement mindset to be able to do this type of work.
Thank you, Sadhna. Thank you for that. Very helpful points. Allison Clearfield, as a health insurer for the vulnerable, what are the pain points? Allison.
That's great. I just want to agree with everything that's been said before. I think the issue of speaking the same language, understanding what is it that as the healthcare system we're really trying to promote. I think we spend a lot of time as a health insurer, a lot of us in terms of trying to address a healthcare need. That's a little different. You know, address a healthcare need or provide a healthcare service. That's a little different than promoting health. They're not quite the same thing. And we do speak different languages. I'll say one of my experiences is trying to get different groups of people from different sectors to define the words case management. That's just an exercise in watching people talk past each other and say, when you say case management, what actually, like, what are you doing? What do you ask, you know, what do you do on behalf of the client? So really understanding that is critical to creating partnerships and addressing pain points. I think another really important thing to talk about is the fact that, as you mentioned, if somebody's going to the doctor, even someone who's really connected to the healthcare system, that's maybe 15 minutes of their life, maybe a few times a month if they're very connected. Think about how many other hours there are in that person's life, and thinking about what are the things in healthcare. We say social determinants of health, which is a fancy way of saying everything else that is important in people's lives, and thinking about what would it take for somebody to have the conditions around them that make healthy behaviors easy choices and default choices instead of hard choices. So housing is absolutely critical to that. I actually come more from working on the homeless services side, where I'm sort of, a lot of my work is thinking about, okay, someone who's experiencing homelessness and vulnerable, what does it take to gain that person's trust, move everything in the system, and actually get them into housing? That's so much work that it's very tempting to feel like you should stop there, but you can't, because housing is just that necessary condition, right? But it's not sufficient on its own to help someone achieve that good health and maintain, the full wellness. And I think as a health providers, insurers, and hospital systems, it's a kind of feeling, especially with housing and the crisis we're in right now here in Los Angeles and across California and the United States, it's a feeling of knowing we can't do our jobs to promote better health for patients without housing being available, but it's real hard to address.
Great. Excellent points, Allison. Thank you for that. All right, next slide. Let's move on. So Gary Blasey, as a policy advocate for the homeless, what are the policy challenges we face in LA to coordinate care for the vulnerable? Gary. Oh, Gary, you're on mute. You're on mute. There you go.
Yeah, I come at this from a perspective of believing that people basically need the same things, and that homelessness or being housed are conditions rather than qualities of people. So they're pretty much all the same, just the challenges are different. I was going to talk about something entirely different, but I've sort of been consumed lately in estimating with some other scholars the number of people who are likely to become homeless in the next period of time. And just to share that, it's quite possible that the number of homeless people in Los Angeles, for example, will more than double in the next few months. And meeting both the emergency or transitional housing, interim housing, shelter needs of those people, and dealing with the healthcare and mental health care of those folks will be quite a challenge. And I think it also offers an opportunity to take some of the lessons that have been learned in the housing as healthcare arena and in the general homeless services area and move them to this spot. And I would say the biggest policy challenge comes from the way that systems have been set up and funded so that it's very difficult for people to be responsible across disciplines for a person as opposed to a piece of a problem. So we have accountability systems that work based on what did I contribute that's within my portfolio. And if everybody does that, the person can still have a terrible outcome. We need better systems where there are cross-disciplinary teams that have collective responsibility for outcomes. And those are funded in a way that makes that possible. We've seen some good infusion of that thinking, I think, in our LA County Housing for Homeless program and the use of Medicaid funds and so on. So I think we're just going to have to do a lot more of that. I think also the risk is going to be that we're going to have to spend all of our time dealing with emergencies and not be able to make as much progress as we could on these system design issues.
Thank you, Gary. Thank you for that. Very helpful points. Fernando Torres-Gil, as a policy advocate for the aging, same question. What are the pain points?
Well, thank you. It's good to be with this group. I would, not to be flippant, but I would say one immediate pain point is age, meaning just to get older. And the pandemic has brought out the great vulnerability based on age, as well as health and income, social isolation, and geography. The highlights, of course, are the nursing homes and the long-term care facilities and the disproportionate number that have been infected and passed away, and the difficulties in providing care. So the issues of age become even more paramount in terms of vulnerability and how we will address it here in Los Angeles City and County. I would add a few others and later talk about how we can respond. The pandemic also brings out something that's been quite an important pain point, as you use that term, social isolation. We know from the National Academies of Sciences and Medicine, etc., that the extent to which one is isolated from social interaction has all kinds of consequences for health and mental health. Again, this pandemic only accelerates that isolation. And we're also finding that more and more of an aging populations are either living alone, never married, do not have children, or are estranged from children. And increasingly, it also becomes an issue of gender. We know that age and female status is also a vulnerability if one does not have appropriate income. So we're facing this issue, and it's a bigger policy and demographic issue, because between now and 2040, we're going to see a doubling of the older population. But some good news, in LA County, LA City, we have a large proportion of persons 65 and over. And LA County City is resource rich, meaning there's a lot of good services. At the moment, LA County, LA City, who have separate departments on aging, are working to coordinate, consolidate, and bring those two departments together. So we have a lot of resources in Los Angeles area, a lot of challenges. The population's getting older, but age is certainly an issue. And later we can talk about race, ethnicity, and immigration. Thank you.
Thank you, Dr. Gill. Excellent points. All right, let's move on to Sarah Hunter. Sarah, as a researcher of government programs serving the vulnerable, your thoughts on pain points. Sarah.
Sure, great to be with you all here today. You know, we face many challenges in providing care for our vulnerable individuals in LA. First off is that we lack access of affordable housing, and second, we lack funds to provide robust services. But there are pockets of hope. A few years ago, RAND was asked to evaluate the impact of the provision of supportive housing provided by LA County's Department of Health to individuals experiencing homelessness that were frequent utilizers of the county health services department. And we looked at the first 890 individuals enrolled in the program and found dramatic decreases in costly health service utilization, primarily emergency room visits, hospital stays, and crisis mental health care after the first year of receipt of housing as compared to a year before people received housing. And this program continues to operate and has housed over 4,500 individuals to date. And in 2016, it was expanded to serve populations exiting LA County jails who were suffering from multiple chronic conditions and who would otherwise be homeless. And we found that this program has also documented high housing stability rates, and we hope to later examine the impact on county service use. And what's really remarkable about these programs in LA County is that, you know, LA County has decided to take dollars and allocate it for healthcare and provide housing, and it's leading to potential cost offsets. But we're limited in our ability to scale up these programs and provide adequate supportive services. For example, these programs build on the idea of housing first, which is housing provision before providing hurdles or preconditions to move into that housing. But actually what happens with these programs is people wait several months to move into housing, partially due to the limited affordable housing stock. And then we've also learned once people move into housing, they're challenged by their ability to thrive in these settings. Because participants are typically assigned multiple people to help them manage their housing, manage their health, manage their involvement with the criminal justice system and other issues. And at the same time, they struggle to find meaningful involvement in their new home, in their new community once they're housed. This suggests there's just a lot of room for improvement in these supportive housing models. The care is often siloed, as we've heard from others, due to funding mechanisms and regulatory concerns. And so rather being designed on evidence base and being focused on the patient, there is room for cost efficiency and removal of silos.
So thank you, Sarah. Important points. So, panelists, before we move to the poll question, we have a minute for any quick comments. Very, very brief 30-second comment. You can unmute yourself and I'll call on you. Brief comment, 30 seconds. Okay, well, let's move on. Let's move on to our poll question. Next slide. In light, and this is for the entire audience, in light of COVID-19, what is the level of urgency to find solutions to the pain points that prevent housed vulnerable people from thriving for the long haul? Again, based on what you've heard today, what is the level of urgency? Please vote. And Christina, will we see results or we'll do that later? Okay, I think we're going to do that later. So thank you for voting, everyone. Let's move on to goal number 2. Review the elements of a housing-based partnership called Support and Services at Home, or SASH. I'm going to introduce Nancy Rocket Eldridge, CEO of the National Well Home Network and creator of the SASH Population Health Model. I took Nancy's class on this topic a few years ago. I said, Nancy, we need to talk. And so now here we are. Nancy, take it away.
Thank you, Ayako. I've always been so impressed with your commitment to population health and particularly by your perseverance that this seminar is actually happening. So thank you for that. And it's been great to get to know Tim and Christina and all the awesome panelists on today. I really appreciate this opportunity to talk about such an important topic. Today I wanted to begin, and if we could move to the first slide. I wanted to begin, next slide please. There we go. I want to talk about why we created the SASH model, what it is, and what its outcomes have been. This first slide I just love because it is a familiar and vivid image of what we know about the impact of health inequities. That on the left you see people who have lived lives of poverty, lives of injustice, and they are literally looking at an immovable brick wall. But when you look to the right and you see that a platform has been built, in this case we're talking about a platform of housing, everyone can see beyond the barriers. Everyone can see the tools and the possibilities for their future, and that's what SASH is about. Next slide, please. So as Ayako said, the biggest determinant of health is our behavior. And when we started creating the model, we met with 82 elderly, low-income seniors in Burlington, Vermont, and asked them to help us design a model. And what they taught us first thing was that there is no change without empowerment, and that the empowerment muscle gets stronger when you're able to articulate what matters to you, and that you're supported by a continuous team, you know, getting away from episodic care toward this idea of embedding a continuous team where trust gets built over years. And so, well, we were, as some of you will remember, back in the mid-2000s, a lot of our discussions were around rebalancing Medicaid. Remember, moving investment in Medicaid funding into institutions and moving it out into the community. We started talking about person-centered care, and yet, at the same time, the healthcare system in the silos, as others have mentioned, just wasn't conducive to anything holistic or connected or continuous. So we had to start connecting the dots. And we knew, as Jenny knows on this panel, the highest need elderly actually live in publicly assisted housing, and that those high need residents are the primary care practitioners' highest need patients. So we thought, perfect, let's team up, let's harness the power of hundreds of talented, capable housing staff around the state and use it to bolster the healthcare resource and workforce. So Dr. Craig Jones and Dr. Lisa Dulski-Watkins were in the lead at the Blueprint for Health in Vermont, part of our state effort to improve primary care and get it NCQA qualified. And so their idea was, let's start using housers as extenders to primary care practice so that when the patient goes back to being a resident, there's a continuous stream of information and mutual support. Next slide. So the first step we had to do was a community organizing effort. And I spent a couple of years down in Long Beach, California as a VISTA volunteer doing community organizing with legal aid. So that was our task. How do we organize all the primary care practices in Vermont, the medical homes, the 22 housing nonprofits, all the hospitals, AAAs, home health, mental health agencies, and then how do we build from there? Making sure we bring in students, nursing students, pharmacy, medical students, that we bring in the public health department and religious organizations to create volunteer pools. And then of course, we had to focus on the knowledge that this was all being paid for by both public and private insurers, payers. So today we have about 70 partner organizations in SASH, and it keeps growing because whatever anyone wants to use this platform, this infrastructure, this Highway 4, brings in new opportunities for partnering. Next slide. So the core of the model is very simple. It's a SASH care coordinator, or what you might call a community health worker, somebody of the community, somebody who understands the resident population. And in Vermont, we have a quarter-time SASH wellness nurse. In the IWISH program that Shahanda spoke about, that it's a 20-hour a week or half-time nurse, which is much better. And then they, as a team, are supporting a group of residents. So there's no one-on-one partnership with the nurses taking care of a certain set of residents, but together, collectively, again, it's all about collective impact and responsibility for the total outcome of the person's physical and mental health. They're responsible for supporting the team. They're very nimble, they're very fluid. There's no billing, there's no coding, there's no, the SASH team isn't in any way replacing the primary care provider, because we're not doing direct care. We're doing med management, we're doing coaching, but we're not doing direct care. Next slide. So, so on the ground today, we have about 5,000 to about 5,500 participants in SASH. It's completely voluntary, of course, because there is a huge amount of information that is shared, private health information that is shared. And so the first step is inviting people to participate. And if they choose to, that's great. And if they choose not to, that's absolutely fine. About 3/4 of the participants in SASH live in congregate housing of all types, everything from USDA rural Section 515 housing to public housing to HUD 202s to Section 8 voucher housing in the community. And about 25% live in the, larger community, in a single family home, in a farmhouse, in a manufactured home. 73% are over 65. As you probably see in Los Angeles, many of our senior projects actually have quite a few younger disabled people. And so SASH supports them as well, of course. And then last point I would just make is that our whole goal is not to discharge. Our whole goal is to say, let's provide a continuous safety net for residents through their lifetime. And if they choose to disenroll, that's of course their right, but very few people do. There's no cost, and it's really been favorably received in terms of satisfaction. Next slide. So when we were thinking about this model, we had just developed a Medicaid-funded assisted living project and saw that it was too expensive. We just couldn't bring that kind of model to scale. And so we were looking at the literature and saw that there were excellent programs that did great care coordination, others did great self-management of chronic conditions, and others were really focused on transitioning out of a SNF or out of a hospital. And so we decided, well, we'll have to bundle them all up and do all of them, with the key being, begin with a person-centered interview that really lets the person talk about their life and articulate what is important to them. And it's never about losing weight, and it's never about reducing your salt. It's always about life goals around family and friends and being valued. So that's how there's a lot of information there, but we're really focused on understanding the data that we're getting, both those motivating factors for participants, but also the data around health conditions, and then bringing evidence-based practices to the housing sites to work on whatever the data is telling us is the greatest need. Next slide, please. So when we were thinking about this at the beginning, in the late 2000s, we really wanted to be sure that it would be statewide. It was of no interest to any of us to have some boutique project in 1 or 2 properties in Burlington. We really knew that if this was going to really result in systems change, it needed to serve the most rural and the most urban parts of our state. And so, and we also knew that this would look different in different parts of the state. And that has certainly turned out to be true. And that's important, because when you're looking at all the assets that you have in a particular city or county or region, they're going to be different, and how you integrate them into one system is going to be different. But the same goal, integration across silos, across all aspects, so that the whole person is supported. How is it paid for? As I mentioned, the Blueprint for Health was the mothership on this, and they had applied for the multi-payer advanced primary care practices demonstration to bring Medicare funding into what they had already created, which was a multi-payer pool. They were bringing in the final piece of funding. And so, so we were funded with a little over $10 million over 3 years to build those 140 sites located at housing organizations. And currently now, I'm very happy to say that the demonstration, since it ended, the state decided to build SASH into their all-payer model. So again, a Medicare waiver, but a little more permanent, a little more stable and sustainable, which we're really happy about. Next slide, please. So results. So our first goal was to really work on reducing what our Medicaid, talk about pain points, our Medicaid office's pain points were the amount of hypertension in Vermont and the numbers with diabetes or prediabetes. And so we've been very focused on those two, and as you can see from the slide, been really successful in reducing A1Cs and reducing hypertension through controlled blood pressures. Next slide, please. The next area we worked on is mental health, and we were very lucky that our accountable care organization, our Medicare accountable care organization, decided to fund 2 behavioral health specialists in 2 of our SASH sites to see if we could, number one, bring down the stigma associated with obtaining mental health services, and can we reduce ER visits. And the end result, about 2 years into it, is that ER visits have been reduced by 30%. Huge. Next slide, please. In terms of healthcare savings, we were rigorously evaluated for 5 years by RTI, and their conclusion was that we reduced the rate of growth in Medicare spending by $1,450 per person per year in the more urban parts of Vermont. So that's important for Los Angeles because we've got such an advantage in terms of density and volume and proximity that we didn't have. And next slide, we also saw reductions in Medicaid spending, $400 per person per year across the board among the large number of duly eligible participants. And this is almost entirely attributed to reduction in nursing home length of stay. Next slide. So this is a picture of Good Shepherd in Los Angeles, one of the other Irish sites with Nurse Sean Murray at that site, colleague of Shahanda's. And so we wanted to talk a little bit about the importance of housing-based models in this COVID-19 environment. And first, of course, we know that there is a high number of at-risk elderly in housing, but what we've seen is a really uneven response across states in terms of prioritizing settings. We know nursing homes, assisted living, prisons, cruise ships have been prioritized for testing, for mitigation. The prioritizing of unlicensed settings like senior housing has been mixed. And I think that's a good chunk of our work is to make sure that we can make sure those are prioritized and make sure that the NGA and governors and other policymakers understand that these, even though these are independent settings, that doesn't mean that people can live independently without some supports. We've also learned, of course, that, I mean, we've all thought a lot about distance, 6 feet. And so the value of having a decentralized network of population health supports across all housing in a city or a county is particularly important now, where we can bring testing into those congregate settings. We can do bulk purchasing of PPE equipment. And I think most important as we anticipate future waves of COVID, that we work now to make sure we know every single site, how to reach them, how to have a communication system so that if there is the slightest indication of a new wave, that we're right ready to communicate with all senior housing sites. Next slide. So a key message here is just that for us, SASH was a process for looking at all the assets we had in our state, how to connect them up in a way that used everyone in the best way possible, reduced duplication, and most importantly, get benefits out to people who sometimes didn't have those benefits and should have. So it's not a program, when we first started this, we had a rural PACE program and people were like, well, do I have to choose between SASH or PACE? And it's no, of course, they work together. And the more we can integrate them so that we use the resources from PACE to integrate, all the better. Next slide. Key takeaway here. Do I need to say more? It's about empowerment. And last slide, I wanted to show you the locations of HUD's Integrated Wellness and Supportive Housing Initiative. Thanks so much to HUD leadership, Leila Lozier, others at HUD for just making this amazing demonstration happen. There are 40 sites in 7 states. You can see the little dots on the map. California has the majority, largest chunk of sites. They have 15 sites, or over 30% of the sites, and you can see on the slide, 3 are in Los Angeles with a total of 470 units. 6 others are in the Southern California area in San Bernardino, San Diego, And then there are 6 others in northern Vermont and northern California, Oakland, San Francisco, up around Sacramento. So this iWish is very similar to SASH, and the demonstration is wrapping up in September. We're hoping it will be extended. We know there's interest in an extension, an appropriation to extend it, because the results of this won't be out till 2022. So thank you all for all your work on iWish, on SASH. Thanks to the panelists. Thanks to each of you for incredible work, and I hope we get to work together more in the future. Thanks, Ayako.
Thank you, Nancy. And before we move on to goal number 3, I'd like to invite the panelists to click back on gallery view so that we can all see each other. Okay, goal number 3. Discuss what housing and healthcare wellness elements and partnerships we have in LA that can be strengthened to help residents synchronize the right care at the right time to stay healthy at home over time. So Nancy describes the SASH elements. What do we have here in Los Angeles that we can work together on now? So Jenny Scanlon, as a public houser, how could your organization change, or what would help you move a large and growing vulnerable population from episodic to continuous care? Jenny.
Thanks. I think the SASH model is a fantastic one for us all to learn from. I think Nancy made a lot of really important points that I don't want to repeat, but I think it's important to understand for us. Connectivity matters, not proximity. Just as an example, on 14 out of 14 of our public housing sites, on 8 of them, we have existing healthcare centers. So we have Altamed, we have wellness centers on site with doctors and nurses on site providing treatment, practice, immunizations. The proximity isn't what matters. What we think it is that connection to the healthcare provider, the connection to the desire for a healthier life, right? And how to create that connection. I think Allison spoke really eloquently about that in her first few points. So I think creating a culture of health on our sites is going to be a huge organizational sort of change agent for us, and I think that starts with this concept of community health workers, or having ambassadors of health within the community that are connected to the residents, who the residents can create a trust relationship with, and that can actually sort of speak to their more personal needs that are really impacting their ability to get healthier. I think control, secondly, is critical, and Nancy spoke to that. Taking control of their environment, feeling some control in their life is absolutely critical. We've done very simple things like started walking clubs in areas where people feel that they have a safety threat or security threat in their neighborhood. They're not even comfortable outside of their home. So just starting that walking club, getting a group together to walk together to support each other makes a huge difference. They begin to feel some control over their environment. So I think those are kind of big changes we can make as we sort of facilitate sort of healthcare on our sites as an agency, and with other agencies trying to serve the community. Data sharing is I think critical, and finding ways that we can get the clients to agree to share their information with us, and then how do we create a system that shares information will be, I think, really important.
Thank you, Jenny. Fantastic point. Right, so let's move on to Sharonda Carter-Cottrell. So Sharonda, as a housing-based nurse, your thoughts on what your organization can change or what help you need?
Sure. Prior to the launch of the iWish program at Vista Tower Apartments, there was a strong sense of community already in place. However, the iWish program is the glue that brings residents, staff, resources, and service providers together. Our site has successfully held cross-agency meetings where we discuss the needs and challenges of the residents from different perspectives. And to further support the program's success, the participants could benefit from having a contract in place for non-emergency transportation to support health and wellness. Examples including a Lyft, Uber, and a service called Butterfly. Residents are encouraged to socialize and increase or maintain activity with assistance to and from destinations of choice. A new focus would be to address the many in-home supportive service caregivers that are underemployed through state funding. iWish should be familiar to all service providers, especially the caregivers, because they are able to support ongoing insight to the residents' needs. Education, support groups, and resources for the caregivers and family members are an aspect of the program we have yet to accomplish on a consistent basis. In addition to having a partnership with a language competent medical doctor, we could see a great benefit in the use of complementary alternative medicine. Evidence has proven that services including acupuncture, massage, occupational and physical therapies aid in the well-being of the individual. In my experience as an iWish wellness nurse, we have successfully aided many seniors in temporary and permanent transitions to and from hospitals, rehabilitation centers, and family homes. In the 2.5 years since beginning the demonstration, it has been very rewarding to support aging seniors through health maintenance, transitional care, end-of-life planning, and death. In relation to the COVID-19 pandemic, we are actively seeking solutions to the chronic health issues. The effects of social isolation include stress, anxiety, depression, and general weakness. These issues have a greater negative impact on the senior population. There is a disparity in access to social media to address the isolation. Solutions may include encouraging the use of electronic devices to maintain relationships and healthy behaviors. And to add, it would also help our community to gain a partnership with insurance providers, Medi-Cal, Medicare, to ensure that we are using all the benefits that are available for use as resources.
Great points. Thank you, Sharonda. Diane Davis, as a health educator, your thoughts on what needs to change or what would help you? Diane? Mute?
Yep. Hi. You know, I think that what's really important in any kind of health education scenario is that you really have to keep the focus on what the person wants, and we've heard that from other people as well. But if you're not initially working with their self-motivation and the goals that they're seeking to solve, you're not going to have success. So you don't go in with a didactic kind of a system. You go in with a community health worker or somebody who speaks the same language, comes from the same cultural background as the person or the people that you're working with, and gain that trust. It's the same trust that Jenny was talking about. I mean, I see that with a lot of my staff and our volunteers. Really the way that we get people into the workshops is by developing a long-term trust relationship with folks that live in these different housing sites. I think in light of the pandemic, what we really, our biggest concern and our biggest issue right now is really that digital divide, because we can't do in-person workshops. We can't do group, you know, all of the health education that my department does is with groups. It's not one-on-one. And we can't have those types of group workshops. So what we're doing right now is we're vetting a number of different technologies, GrandPad, Uniper, talking to T-Mobile. I don't know if you guys all know, but in New York City, T-Mobile and the city of New York are providing 10,000 tablets to people that live in HUD housing in the city of New York. We need something like that to happen here in Los Angeles. And you know, I'm starting to have conversations with someone from T-Mobile, talking to the city and the county departments of aging about using maybe 3D money towards, which is now allowed under some of the changes that have been happening at the federal level. You can use some of the monies that were previously only allowed to be used on programming. You can now use to purchase some of these types of devices that help people get connectivity. And ultimately what we're trying to solve is I mean, a bunch of issues, but a big issue here is social isolation and loneliness.
Yeah, great points, Diane. Thank you very much. I'm hearing these repeated issues popping up. All right, let's move next to, next slide. Yes, so to Sadhna Devaraja, as a systems upstreamer, what current regional networks or partnerships do we have, and how can we build on those to meet these needs? Sadhna.
Thank you. And so at Health Begins, we work across the country, and I'm going to speak to the type of networks and partnerships that are forming, because I think the specific network or partnership that would be helpful for an individual or an organization will really depend on their unique goals. And so rather than kind of list out something, I'll say that, you know, the current networks and partnerships that are popping up all over are really embracing that spirit of continuous improvement that I spoke about earlier. So everyone's recognizing we need the capacity to quickly learn from each other, to kind of implement best practices that we're learning from each other, to disseminate them, and to pivot from what they're doing. And so that need has always been there, but especially in this moment. And so there's this opportunity to build sustainable partnerships that are really coming from this moment of fire. And so, you know, what are we seeing? We're seeing partnerships and coalitions coming together on advocacy, on kind of like forcing implementation and learning from each other's missteps, learning how to do more with less, making their best practices public. And, you know, you just have to look at like the Western States Pact to see what kind of unlikely alliances are now coming into being. Look at the telehealth barriers that are being disrupted. Look at the work that CDFIs are doing across the country, LISC, Enterprise, Nonprofit Finance Fund. They're all, you know, these great networks that are really just trying to figure out whatever dissemination vehicles need to exist to be able to get people to do this work faster and better, and the kind of shortest timeline possible is what they're doing. So there's immense opportunity to think about what you want to get done in your setting. I encourage you to think ambitiously and to work on setting that up now. We've been helping our clients do exactly that. I know Diane mentioned the digital divide issue. We've worked with clients trying to partner with educational systems who are also dealing with the digital divide issue in a different way. And so these, you know, kind of allies are really coming from all sectors because we're all trying to solve the same problems. And so whether it's building a partnership to address social needs like an individual's housing, thinking collectively about housing stock, thinking structurally about undoing redlining or decarceration, I'll say you will find an ally in that work today. You can build that partnership today. And so I'd urge people to think about what they want to see on the other side of this and, you know, seek out those partnerships or build them yourself.
Thank you, Sadhna. Fantastic. Let's move on to Allison Clorfield. As a health insurer, what do we have? How do we build on what we currently have? Allison.
That's great. So I'll say in terms of some of the things we have going for us here in Los Angeles, there have been a lot of efforts to bridge actually often health and homelessness. And I think that there's a lot of opportunities on the healthcare side. There's a real interest that we've seen from our healthcare community clinics, Medicaid health insurers, hospitals, public hospital systems to want to move from addressing health and homelessness to also addressing health and housing as a connection. So we hosted a summit with partners from the Medicaid system in October talking about that. And there's a real goal to be joint policy advocates and to develop new partnerships. I think we're really lucky and at a good moment in terms of the healthcare system realizing more and more that the connection to housing is absolutely integral to health. Unfortunately, it took a homelessness crisis to get there, but we'll take you know, the silver linings where we can find them. I think another thing we have going for us in our region is the state master plan on aging and local regional kind of master plans on aging. There hasn't necessarily been a health housing focus in those plans yet, but I think that's another really good place to dig into. And then I think the last kind of partnership to really highlight is we've had a really great success so far working with the other Medicaid health plans here in LA County on the county whole person care and health homes pilots, which were new programs started in 2016 and 2019, just last year, to try to provide more intensive case management through Medicaid to vulnerable populations, especially people experiencing homelessness or with multiple chronic conditions. So we have a lot to learn from there, but just a couple things that are barriers we need to think really carefully about in looking at models like SCANPH. So one I'll say is that even in Medicaid, Medicaid covers 3 out of 10 people in LA County, but we have 6 different health plans and we all work together collaboratively, but from a provider perspective, it might mean, okay, am I calling Allison at LA Care? Am I calling Scott at HealthNet? It's annoying to have to deal with multiple agencies, we know, for providers to have to deal with multiple partners, but that's our system. And I think another thing to think about here in terms of coordination is thinking about, are we investing in partnership through people? Are we building up teams of people who run around to integrate all the systems by their force of will? Or are we building up data sharing or technology that brings the information together into people? LA County's focused a lot more on, so far in our case management programs, getting great human capital, and I think we're missing some of the technology side.
Excellent points, technology side. That's a whole different conversation. Thank you for that. All right, let's move on. Next slide. Gary Blasey, as a homeless advocate, what current legislation or policy changes would you recommend to address these needs? And who do we connect with to continue this important discussion? Gary.
Thanks for that question. Because having housing is probably one of the things that's most critical to health, keeping people in housing is more useful than anything you can do after they become unhoused. And as I mentioned earlier, we're going to face an explosion of homelessness absent some more powerful interventions than we've seen. The ones that actually have some promise, unlike some of the other moratoria, et cetera, are proposals in the Senate and Sacramento to basically enable the state to pick up the rent for people who would otherwise be evicted and let them pay that back over a 10-year period at no interest. That's sort of parallel to some of the demands from activists to cancel rent, but the problem with those is that they're probably unconstitutional and therefore not very effective. The other is that we need to delay the onset of that crisis. We need to flatten the curve, if you will, by delaying the onset of those evictions. Right now, they're frozen by the Judicial Council of California, which can release that freeze at any time. And the governor and the Judicial Council, either one could extend that, but there's going to be enormous pressure from landlords, probably including folks who need to get rent from their residents in low-income housing to let evictions begin. But if we can't lay it out a little more longer, it's going to be much worse than otherwise. And the last thing I'll say is that there aren't any specific proposals to deal with this now, but we definitely need a legislative focus, a policy focus on dealing with the terrible racial disparities in all these problems. I just read that African Americans are 3 times more likely to die of COVID-19. And in Los Angeles County, African Americans are 11 times more likely to be homeless. So that's a disparity that cannot be allowed to continue.
Thank you, Gary. Important points. And well, let's just move on to Fernando Torres-Gil. Same question. What legislation or policy changes would you recommend?
Thank you. I'm going to build in part on Allison, but certainly what Gary's comments have made. There is now a recognition at the state level that we need to move towards both coordination, using data to understand where we target problems and solutions, and also begin to look over the horizon and plan ahead. And prior to this pandemic, Governor Newsom, who really knows issues of housing and homelessness and aging quite well, came up with a master plan on aging and brought together, I think, really all the key players to start sorting out the many different issues related to the aging of California and how to respond to older adults as well as persons with disabilities. So prior to the pandemic, we also, among the many things, had great hopes that California could emulate Washington State and Hawaii State and begin to develop at least a financing mechanism at the state level so individuals could stay at home, hire caregivers, and provide the necessary services to age in place, so to speak, because that's really where folks want to be. The pandemic has actually added more momentum because we more than ever realized institutional settings are not always the safest place in terms of the pandemic. The dilemma at the moment is this pending recession, and the governor's budget at the moment have proposed deep cuts in some of the essential programs, in-home supportive services, the MSSP program, and others. So many of us advocates are working closely with the state and with the state legislature and the governor's office to at least keep that safety net intact until we bounce back with the recovery. On the good news, in terms of the federal level, notwithstanding the huge polarization, and we won't get into the messy national politics, one of the nice things about our issues of aging, housing, homelessness, social safety net, increasingly it has bipartisan support. The Older Americans Act was reauthorized with funding increases. There is recognition on both sides of the aisle that housing and home and community-based services in fact matter. Great recognition that we need to rethink institutional and nursing home care. So the momentum, even in these tough times of politics and this virus, I think are moving us in the right direction. So I would suggest those areas. And then lastly, my last point is we cannot forget the issue of the workforce. Who will care for whom, whether it's in public housing, at home, community-based services, and that's another big discussion about the workforce and the direct care workers. Thank you.
Yeah, excellent point, thank you. Let's move on to Sarah Hunter. Sarah, as a researcher, same question. What would you recommend?
Sure, as noted earlier, we need to provide supportive housing in our community. Because funds for housing and supportive services have historically been provided by different federal agencies, there's the need to bridge efforts. California has been successful in bridging the gap. Take, for example, Proposition 2 that was passed by voters in 2018. That allows for state tax dollars allocated for mental health services to now be applicable to supportive housing. And since we can't build our way out of the housing shortage that we're in, we need to think creatively to take existing structures and turn them into supportive housing. So to try to make lemonade our recent pandemic, which brought along Project Roomkey, which is providing shelter in the form of hotel and motel units, one potential change worth building upon is having the government take over or provide continuous access to these hotels and motels and potentially converting them, some of them, to permanent forms of housing with on-site care provided. Depending on need, the provision of medical and mental health care rather than traditional forms of case management, which rely on a high level of referral-based care, is needed. So that is removing the number of people providing these supportive services and providing a higher level of wraparound services to participants will potentially result in better outcomes and less reliance on emergency high-cost care. So building funding mechanisms that allow for more flexibility in the provision of care are needed. Thanks.
Great points. Thank you, Sarah. And for the three policy people, who else should we be speaking to and include in part of this discussion? Any thoughts? Fernando, Gary, Sarah?
AARP.
AARP, yep. Mm-hmm.
And Justice in Aging, a very effective litigating advocacy group, Justice in Aging.
Yep. Okay. Anyone else? Who's missing from our conversation?
I think you can talk directly to policymakers.
Mm-hmm. Great. We'd love to get them involved. Absolutely. Gary, any thoughts?
And I'm not.
Oh,
Oh.
Go ahead, Allison. Allison?
I'm jumping in, pretend policymaker. But I would say also thinking about the parallels between the issues we're discussing around aging and housing, healthcare and housing. I think a lot of the same issues exist for people who have developmental disabilities in terms of the need to really connect housing and services practically. So thinking about the regional centers and other folks there.
Absolutely. Great.
I also think National Council on Aging has a really good advocacy arm to it, and they're another really good place for doing advocacy for these types of services.
Great points. And Gary, you wanted to make a point? Mute button. Gary, your mute button.
I'm a slow learner. I think it's important for people to get a sense of the level of activism and advocacy that's going on in the private sector tenant organizing effort, because there's 1.9 million apartments in LA County, only a tiny fraction of which are in the sector that we've mostly been talking about. So most of the action that will determine what we see on the streets is going to be in that sector. And the issues of healthcare have not much got into those conversations. I think it's important to help educate some of those people making those cases that one reason to keep people in housing is not the most obvious, but a really critical one is that housing is really a predicate to good health.
Yep, great points. Thank you. So before we move on to the audience Q&A, all panelists, final thoughts, anything that was said that you would like to add? Just unmute yourself and I'll call on you. Anyone, final thought? Okay, so why don't we, before we move on to our poll question, I wanted to ask any questions in the audience to go ahead and submit them in the Q&A section, and then we will address those. So let's go to the next slide. Poll question number 2. To what degree does the greater LA area need a regional housing-based care coordination model or network for the vulnerable? So go ahead and vote. Okay. And as we're tallying those results, we will look at the questions posed to us so far. So the first question I have from the audience from Lillian Gilberg: is the care coordinator like a community health worker? What is their training, and do they have lived experience? So I'll give that question to Nancy Eldridge. Nancy?
Okay.
What is?
Thank you. Thank you. So yes, absolutely right. The care coordinator is similar to a community health worker, really looking for people with the characteristics of empathy, of ability to juggle many issues at the same time. We do not have a set of required licensure. We don't require, for example, that the coordinator be a social worker. And in terms of life experience, lived experience, we've seen all sorts of ranges of, we have 130 staff that are SASH coordinators or nurses in the program, and some are just out of college and incredible, energetic people, and we've seen, senior citizens who certainly have life experience. So great question.
Great, thank you for that. And we have another question from the audience from Christina Badiati. I'm curious to hear more about how site-specific environmental health, that is indoor quality, indoor air quality, walkability, heat, shade, green space, public space, then again, that's environmental health, is considered in this continuum of care, and what are the limitations what partnerships or funding streams are needed, spoken like someone from environmental health sciences, Christina. So who would like to take this question? How does site-specific environmental health play into what we're talking about here? Anyone?
I'll take it.
Yes, please, Allison.
Oh, I think that was Jenny. Go for it, Jenny.
I'll add if you need.
Oh, I'm sorry. Yeah, both of you. Yeah. Jenny, go ahead.
Just briefly, I think in terms of some of the healthcare issues, there's some good evidence around specifically issues around pest control and asthma. I think that sometimes with other environmental determinants of health, they're sort of slower acting. So while you can get really great results for people over time by making a healthier built environment or addressing things overall, it's sometimes harder for those of us on the healthcare side to see that investment. So often it's really thinking of it from more of a public health or environmental health mindset is better because it just takes time.
Great. Thank you, Allison. Jenny?
Yeah, I would just say from our perspective, it plays a huge role in health. And we know that when we look at the statistics of our communities and who's doing better and who isn't. We're very lucky, I think, in the state of California to have cap and trade and to have the focus of so much of the cap and trade dollars come in for housing and for the improvements that we need in those communities to really address some of those environmental inequities. And we know within our public housing, it's an older stock of housing. We don't have air conditioning. And we live in some of the hottest parts, our population's living in some of the hottest parts of the city because of the heat island effect. So when summer comes, you're gonna see higher rates of death, you're gonna see higher rates of violence, you're gonna see all kinds of health issues rise because they're not living in an environment that is conducive for their health. So I think there are a lot of things that we need to do as we're building housing, as we're putting investments in communities to really address the environment around that housing and the environment in that housing to really hit on those points. So we're working on that, but there's lots of more work to do.
Great. Thank you for that. Anyone else? Yes, Sadna.
Hi. Yeah, I love this question, and so thanks for letting me have a chance to. But also with the providers and healthcare systems that we work with, this can be part of the continuum of care in kind of two regards. One is on the screening side of things. Two, validated screening tools, the AHC CMS tool, as well as the Prepare screening tool, have aspects of that question in them. It's not as comprehensive as the question was, but housing inadequacy to the point about pests and mold and our indoor air quality is on the AHC screening tool. And so that's something that providers and health systems can use to assess whether someone has issues with their housing adequacy. And then on the Prepare tool, they even have a slot for entering the address, and it's geocoded to kind of social vulnerability. And there are Z codes attached to kind of some of the exposures related there. So I think that that's one part of it. And on the other end of the continuum, we do work with our partners to think about environmental justice issues for the communities they serve. And so there's on one level, the screening individual needs part of things. And then also as we look at health systems and kind of larger organizations, what they can use their power and weight to advocate for.
Thank you, Sana. Great points. Yes, Sharonda, please. One last comment. Sharonda?
Oh, thank you for asking the question, Christina, about proposing that, because I didn't think about indoor air quality and being one-on-one with the residents and building that rapport and trust. I have observed, because we're fortunate and we have experienced the remodeling during our demonstrations. So all of the units do have air conditioning, but I will mention that safety, environmental safety is a big aspect, being from home health with residents being home more often, there's a greater risk of falls. And so I am assessing the units individually and offering information, which is another big thing. Funding for presentation information is how we can address those things as needed, because we have public space. The community rooms are being utilized by the residents, but we do not have space at our site for green space. So just information for maybe relatives' homes they could go and visit and participate in. But just, I appreciate the idea to focus on that as well.
Thank you, Sharonda. And fortunately, we are all out of time. This has been a fascinating discussion. I wanted to close out by noting that it is incumbent upon us to design a system that works for vulnerable people. So what can each of us do to make that happen? I want to thank our panelists, Gary Blasey, Sharonda Carter-Cottrell, Diane Davis, Nancy Rocket-Eldridge, Sarah Hunter, Allison Clorfield, Jenny Scanlon, Sadhana Thevaraja, Fernando Torres-Gill, audience in UCLA Ziman Center for Real Estate. I leave you with a quote from Ron Silverman by Anonymous. What do we learn from cows, buffaloes, and elephants? It is impossible to reduce weight by walking, eating grass, and salad. I leave you with this thought on the shutdown. What did our parents do when they were bored before the internet? I asked my 26 brothers and sisters, and they didn't know either. Back to you, Christina. Thank you, everyone.
Thank you again, Ayako, so much for moderating today. And a huge thank you to all our panelists. We hope everyone, each of you in the audience, has learned something new or been inspired by the discussion on today's topic. We'll continue to connect with us. Hope you continue to connect with us on issues of housing and healthcare. And we look forward to seeing you again. Be well. Good afternoon. Thank you.